Hello everybody. Now we have to speak about post-traumatic CSF leaks and cranial base reconstruction. I'm Angelo Pompucci. I'm a neurosurgeon and I'm speaking from Italy. First of all, I would like to thank Professor Mezzadri and the friend and colleague Dr. Matteo Baccanelli for this really kind invitation to the 47th Congreso Argentino de Neurocirugía Virtual. There are no potential conflicts of interest. Now we have to speak about the post-traumatic CSF leakage and cranial base reconstruction. Firstly, we have to address the classifications. CSF leakage can be described as traumatic or non-traumatic, and acute or delayed considering the timing, and close head injury or penetrating injury considering the pathophysiological mechanism. Speaking about pathophysiology, for CSF post-traumatic leakage occur, we need for a communication between the inner intracranial space and outer space, such as, for example, paranasal sinuses. And we need the presence of a breach in the dura mater. Usually, traumatic CSF leakage starts immediately after the trauma, and 95% of them occur within 3 months. We need to remember that more than 85% of traumatic CSF leakage stop with observation or non-surgical treatment. It has been suggested that the mechanism close to spontaneous resolution is the presence inside or around the defect of regenerated mucosa or fibrous tissue. Contrariwise, the presence of encephalocele or a meningocele through the bony defect may disallow the healing process. Furthermore, to have a communication and a breach in the dura layer, we need for a skull fracture. The size of the fracture, the site of the fracture, and the anatomy of the dura at the site of the fracture are very important factors. For example, the cribriform plate, where the bone is really thin and fragile, and a true dural investment is usually missed. Furthermore, for anatomical reasons, the plate is at the bottom of a medial slight slope, where the CSF may gravitate. Also, for the skull fracture, we need a classification. Skull fracture may be divided in linear fracture or depressed fracture, involving the vault or the skull base, open or closed, involving the different bones and regions. The SACAS classification is a really useful classification for clinical reason for the anterior skull base fracture. He divided the fracture in 4 types. Type 1 fracture. This represents the 60% of the anterior skull fracture. In this case, the fracture involved only the cribriform plate. Type 2. In this case, the skull fracture involving the anterior skull base extends from the cribriform plate to the anterior or posterior walls of the frontal sinus to the ethmoid sinus. Type 3, in this case, the fracture is more lateral, involving the superior or inferior wall of the frontal sinus and continues in the medial superior region of the orbit. The type 4 fractures consider mixed fractures. So, using this classification, we can define patient at risk to develop prolonged CSF leakage after trauma and a major risk to develop post-traumatic infectious complications, such as patients with type 1 and type 2 fracture, large in size, with a fracture displacement measured than 1 centimeter, are at risk. For the temporal bone fractures, the Ulrich classification may be really useful. This classification provided 3 types of fractures: longitudinal, transverse, and mixed. The presence of longitudinal fractures in the temporal bone is associated to a higher risk to develop post-traumatic leakage, up to 70 to 90% of cases. For the diagnosis, all of us know the clinical signs. For example, bending down the patient's head, we can provoke the getting out of CSF through the nose. This is the reservoir sign. And we collect on the gauze these nasal secretions, individuating the target sign or double ring sign. Clinical suspicion for the presence of skull fracture may arise in case of the presence of the battle sign. For the temporal fracture, they recognize for the anterior skull base fracture. Furthermore, the presence of cranial nerve palsy may suggest the presence of skull base fracture. Diagnosis may be obtained using chemical process. We can find the presence of glucose in the nasal secretion, the beta-2 transfer with the high sensitivity and specificity, beta trace protein test, which has similar sensitivity and specificity of beta-2 transferrin, but is really faster and less expensive. Considering the imaging, the high-resolution CT scan is the gold standard technique. Sensitivity and accuracy are really high, and we can use different images in coronal, sagittal, or axial plane to better study the size and the type of the fracture. But we have to keep in mind that the presence of a fracture is not always correlated with the presence of CSF leak. Several examples: axial plane, coronal plane in a case of type 4 Sacas fracture. The 3D reconstruction may be very useful to have a complete visualization of the fracture. In selected cases, computed tomography cysternography may be used. Is really useful when there is an active leak or when the leak can be induced using the Valsalva maneuver. Of course, MRI may be really used in studying this kind of patient. Particularly, T2-weighted sequences or fast spin echo sequences must be used. It's a very valuable technique because CSF gives a power intense signal, but false positive rates up to 40% due to the difficulty to distinguish CSF from mucosal thickening or nasal fluid. In selected cases, we can also use MRI after gadolinium intrathecal injection. The lower viscosity of the gadolinium compared to iodinated contrast agents may justify better results confronting the CT scan with gadolinium MRI contrasted study. Considering the clinical management of the CSF post-traumatic leakage, several authors proposed different treatment algorithms based on the GCS score or the timing of the cerebrospinal fluid leakage, acute or chronic. Conservative treatment might be preferred initially, considering precaution measures such as bed rest and avoiding Valsalva maneuvers, and CSF diversion after 5 to 7 days without spontaneous resolution. Considering prophylactic antibiotic therapy is a still controversial issue. There are proponents and opponents considering lower rate of registered cases of meningitis otherwise increased risk of meningitis after antibiotic suspension. A meta-analysis confirmed that there is impossible to recommend prophylactic antibiotic therapy. Considering the surgical treatment is indicated for cases that doesn't resolve spontaneously after 7 to 10 days, in case of deteriorating clinical conditions, in case of large fractures in the medial line with dural defects, and chronic or recurrent leakage, with or without episodes of meningitis. We can consider extracranial approach is the most used first-line approach for post-traumatic CSF leakage is transnasal endoscopic approach with a high success rate up to 98% and low morbidity. Intrathecal injection of sodium fluorescence solution may effectively improve the efficacy of this technique. Considering the intracranial approach in open surgery, we can use intradural approach, extradural subcranial approach, and intradural extradural combination. There are some limitations in using the extradural open approach. First of all, the risk of damaging the dura mater with difficulties in distinguish iatrogenic lesion from the primary traumatic ones. Final remarks. When we cope with the sulcus large fracture with an encephalocele, we need to plan a weak surgery in order to avoid the expected CSL leak and secondary threatening infection. When an open intracranial approach is requested, our goal is to close the skull base defect using, if possible, a solid strut. In case we don't need an open approach, the endonasal route and endoscopic approach is the gold standard technique. So, thank you for the attention and greetings from Italy. Considering my time is run out, I leave 2 clinical cases without any comment. I hope you can appreciate this clinical situation. Thank you.